No matter how long you have traveled in the wrong direction, you can always turn around. Let us begin with this quote, the today's topic. Today we'll have a discussion on a topic that is ectopic pregnancy. Ectopic pregnancy occurs when a fertilized egg implants and grows outside the main cavity of the uterus. The most common location for an ectopic pregnancy is within the fallopian tube, known as tubal pregnancy. However, ectopic pregnancy can also occur in the ovary, abdominal cavity or cervix. Ectopic pregnancy still contributes significantly to the cause of maternal mortality and morbidity, while there has been about four-fold increase in incidence over the couple of decades, but the mortality has slashed down to about 80%. The reason is advance in ultrasound, particularly the transvaginal scan imaging and sensitive beta HCG assay, have considerably improved the diagnostic capability at the early stage even prior to its termination. We'll move on to the next slide, that is an introduction on ectopic pregnancy. Pregnancy begins with the fertilized egg. Normally, the fertilized egg attaches to the lining of the uterus. An ectopic pregnancy occurs when a fertilized egg implants and grows outside the main cavity of the uterus. An ectopic pregnancy most often occurs in a fallopian tube, which carries eggs from the ovaries to the uterus. This type of ectopic pregnancy is called as tubal pregnancy. Sometimes an ectopic pregnancy occurs in other areas of the body, such as in the ovary, abdominal cavity or the lower part of the uterus, that is cervix, which is connecting to the vagina. The fate of ectopic. An ectopic pregnancy cannot proceed normally. The fertilized egg can't survive and the growing tissue may cause a life-threatening bleeding if left untreated. Moving on to the definition of ectopic pregnancy. A pregnancy in which the fetus develops outside the uterus, typically in the fallopian tube. 1 in every 100 women run the risk of an ectopic pregnancy. Next, we'll move on to the site of implantation. So, we can see the various sites where the ectopic pregnancy can be implanted. So, if you are seeing the fallopian tube, the different parts of the fallopian tube, that is interstitial, isthmus, ampulla and infundibulum. So, we'll just see the site of implantation. The site of implantation has been categorized as extrauterine and uterine. Under extrauterine, you have tubal pregnancy, ovarian and abdominal pregnancy. The tubal pregnancy is one of the most common one, which you can see is 97%, ovarian is 0.5% and abdominal is 1%. So under tubal, you have a different parts in the fallopian tube. Accordingly, based on the implantation of the fertilized ovum, it is divided as ampulla, which is almost like 55%, isthmus 25%, infundibulum 18% and interstitial 2%. If you are seeing under abdominal, that is 1%, it is divided into two types, that is primary and secondary. Primary is rare, which happens in the abdomen itself, the pregnancy, whereas in secondary it is divided into two, that is intraperitoneal and extraperitoneal. Intraperitoneal is one of the commonest one, which you can see. Extraperitoneal, where the rent is at below the fallopian tube, where the pregnancy grows in the broad ligament, and it is one of the rare case. So these are the two categories which you can see in a secondary abdominal pregnancy as intraperitoneal and extraperitoneal. On the other side of implantation, on the other side you have uterine, which stands for 1.5%. So under uterine you have a cervical pregnancy, which is less than 1%, angular, cornual, and in the cesarean scar also, which is less than 1%. So these are the various sites of implantation of ectopic pregnancy. Moving on to the etiology or the causes which are responsible for the ectopic pregnancy. So they have listed down the two factors has been laid down which is responsible for the as the cause for the ectopic pregnancy. The factors which are responsible for the fertilized ovum to remain in the tube are, that is, first one is factors preventing or delaying the migration of the fertilized ovum to the uterine cavity. Secondly, the factors facilitating the nidation of the fertilized ovum in the tubal mucosa. So these are the two factors or the two reasons which are responsible for the development of the ectopic pregnancy. First we'll see the factors contributing or delaying the migration. So in that, the pelvic inflammatory diseases, which we usually call it as PID, it increases the risk of ectopic pregnancy by 6 to 10 fold. And the second reason is loss of cilia of the lining epithelium and impairment of muscular peristalsis. The next reason is narrowing of the tubal lumen, formation of pockets due to the adhesions between the mucosal folds, peritubal adhesions resulting in kinking and angulation of the tube. So speaking about the cilia, that is a loss of cilia. The cilia is a hair-like structure. The fallopian tube is an accessory organ in the female reproductive system. It connects the ovary to the uterus. The inner lining of the fallopian tube is made up of a ciliated epithelium, and they have cilia which help facilitate the movement of the egg to the uterus. Speaking on the adhesions are bands of scar tissue that can form between the surfaces inside the body. In the fallopian tubes, these adhesions can obstruct or distort the tubes, impeding the normal passage of the egg from the ovary to the uterus. This can lead to infertility, increased risk of ectopic pregnancy, and chronic pelvic pain. Moving on to the iatrogenic causes, that is contraceptive failure. The absolute number of ectopic pregnancy is in fact diminished with the use of any contraceptive because pregnancy occurs less often. But in selected contraception failure, there is an increased incidence of ectopic pregnancy. So the first one is IUCD, that is intrauterine contraceptive device. It prevents intrauterine pregnancy effectively, tubal implantation to a lesser extent, and the ovarian pregnancy not at all. There is thus relative increase in tubal pregnancy should pregnancy occur with IUCD in situ. Next one is the sterilization operation, that is laparoscopic fulguration. Sterilization operation, there is 15 to 50% chance of being ectopic if pregnancy occurs following the tubal sterilization. The risk is highest following the laparoscopic fulguration without tubal resection. Laparoscopic fulguration for sterilization is minimally invasive surgical procedure used for permanent female sterilization. This procedure involves using a laparoscope, a thin tube with a camera and light inserted through a small incision in the abdomen to visualize the fallopian tubes. The surgeon then uses a fulguration device which generates electric current to cauterize and close off the fallopian tube. This prevents eggs from traveling from the ovaries to the uterus, thereby preventing pregnancy. The procedure is typically performed under general anesthesia and involves a relatively quick recovery time compared to more invasive surgical methods. The next iatrogenic cause is a use of progestin-only pill. The progestin-only pill, which is called as POP, also known as a mini pill, is a type of oral contraceptive that contains only progestin, a synthetic form of the hormone progesterone, without estrogen. This pill is taken daily and works primarily by thickening the cervical mucus, making it more difficult for sperm to enter the uterus, thinning the endometrium, reducing the likelihood of implantation if an egg were to be fertilized. And third reason is suppressing ovulation. Although this is less consistent compared to the combined oral contraceptives that contain both estrogen and progesterone. The POP is often recommended for women who cannot take estrogen, such as those who are breastfeeding over 35 years and they smoke or have a certain health condition like hypertension or a history of blood clots. It's important to take the mini pill at the same time every day to maintain its effectiveness. The next cause is a tubal surgery. Tubal surgery refers to any surgical procedure involving the fallopian tubes, which are the structures connecting the ovaries to the uterus. These surgeries can be performed for various reasons, including sterilization, that is, tubal ligation, a permanent form of birth control where the fallopian tubes are cut, tied, or sealed to prevent eggs from reaching the uterus for fertilization. And the second reason may be a reversal of sterilization, that is called as tubal reanastomosis, reconnecting previously cut or sealed fallopian tubes to restore fertility. And the other reason is removal of blockages or adhesions, clearing blockages or adhesions in the fallopian tubes that might be causing infertility or pain. So these are the various reasons through which a tubal surgery is done. Next reason is intrapelvic adhesions. Intrapelvic adhesions are bands of scar tissue that form between pelvic organs and tissues. They can result from various conditions and procedures like surgery. Adhesions often form after pelvic or abdominal surgery such as cesarean section or appendectomy. The infections, the pelvic inflammatory diseases or other infections can lead to inflammation and subsequent scar tissue. Endometriosis, this condition causes the growth of endometrial tissues outside the uterus, which can lead to adhesions as the body tries to heal the areas of misplaced tissue. Trauma, physical injury to the pelvic area can result in adhesions. The next iatrogenic cause for the ectopic pregnancy is ART, that is assisted reproductive technology. ART encompasses various medical procedures used to address infertility. These technologies aim to help individuals or couple conceive a child. The primary type of ART includes in vitro fertilization, that is IVF. Eggs are retrieved from the ovaries and fertilized by the sperm in a laboratory. The resulting embryos are then transferred to the uterus. The second one is ICSI, that is intracytoplasmic sperm injection. A single sperm is injected directly into an egg to facilitate fertilization, often used in cases of severe male infertility. The third one is egg donation. Eggs from a donor are fertilized and then implanted into the recipient's uterus. And the fourth one is sperm donation. The donor's sperm is used to fertilize an egg either through IVF or intrauterine insemination. Embryo donation. Previously created embryos are donated and transferred to the recipient's uterus. Fertility preservation. Techniques like egg, sperm or embryo freezing for future use. Moving on to the other causes for the ectopic pregnancy. The reason may be a previous ectopic pregnancy, prior induced abortion, developmental defects of the tube, and transperitoneal migration of the ovum. Moving on to the second factors, that is factors facilitating the nidation in the tube. Early resumption of the trophoblastic activity is probably due to the premature degeneration of the zona pellucida, increased decidual reaction and tubal endometriosis. Speaking on what is zona pellucida. The zona pellucida is a glycoprotein layer surrounding the plasma membrane of mammalian oocytes. It plays several crucial roles in reproduction. That is, the role is protection. It acts as a protective barrier for the oocytes and early embryo. Secondly, the sperm binding facilitates the binding of the sperm to the egg during fertilization through specific receptor. Third reason is prevention of polyspermy, which means once a sperm penetrates the zona pellucida, it undergoes change that prevent additional sperm from entering the egg. The fourth reason is embryo development. Regulates the interactions between the embryo and its environment during early development until the embryo hatches out of the zona pellucida to implant into the uterine wall. Degeneration of the zona pellucida means which can occur naturally during the process of embryo development, particularly during the hatching when the embryo needs to implant in the uterus. But here the reason is there is a premature degeneration of the zona pellucida which can happen in the fallopian tube itself, and it may be leading to the formation of ectopic pregnancy. Let's move on and see what's the morbid anatomy of this ectopic pregnancy. What changes happens in the tube? That is the changes in the tube. Implantation in the tube occurs more commonly in the intercolumnar fashion, that is between the two mucosal folds. The residual change at the site of implantation is minimal. The muscle undergo a limited hyperplasia and hypertrophy, but more stretching. The blood vessels are engorged. The ovum burrows through the mucous membrane and lies deep in the muscle layers, so called intramuscular implantation. A pseudocapillaris is formed consisting of fibrin, lining epithelium and few muscle fibers. The blood vessels are eroded by the chorionic villi and the blood accumulates in between the ovum and the pseudocapillaris. The tube on the implantation site is distended and the walls is thinned out. The thinness is due to the distension by the growing ovum, accumulation of blood and erosion by the chorionic villi. Further changes in the tube, especially at the site of implantation, depend on the mode of termination of the pregnancy, which invariably occurs within 6 to 8 weeks. So we have seen the changes in the tube. Moving on to the changes which you can see in the uterus. Under the influence of estrogen, progesterone and chorionic gonadotrophin, there is a varying amount of enlargement of the uterus with increased vascularity. The decidua develops all the characteristics of intrauterine pregnancy except that it contains no evidence of chorionic villi. When the ovum is dead, it is either disintegrated and comes out as a piecemeal or comes in a single piece. Moving on to the mode of termination. Because of the unfavorable environment, early interruption of pregnancy is inevitable within 6 to 8 weeks. The modes of terminations can be in the form of tubal mole, tubal abortion or tubal rupture. Tubal mole. The formation of the tubal mole is similar to that formed in the uterine pregnancy. The fate of the mole is either the complete abortion, expulsion through the abdominal ostium, or tubal abortion with a variable amount of internal hemorrhage. The ancestral blood so collected in the pouch of Douglas is called as a pelvic hematocele. Tubal abortion. This is a common mode of termination if implantation occurs in the ampulla or infundibulum. Prior to abortion, the ovum may be converted into mole or else a living ovum is aborted. The third one is a tubal rupture. Tubal rupture is predominantly common in ischemic and interstitial implantation. Ischemic rupture usually occurs at 6 to 8 weeks, the ampullary at 8 to 12 weeks, and the interstitial one at about 4 months. Depending upon the site of rupture, that is intraperitoneal rupture or extraperitoneal rupture. Intraperitoneal rupture, this type of rupture is common. The rent is situated on the roof or sides of the tube. The bleeding is intraperitoneal. Extraperitoneal rupture, this type of rupture is rare and it is also called as a intraligamentary. It occurs when the rent lies on the floor of the tube where the broad ligament is attached. It is commonly met in ischemic implantation. In conclusion, ectopic pregnancy is a medical emergency that requires swift and effective intervention. As nurses, our role in early detection, management, and providing holistic care is crucial. By being well informed and vigilant, we can make a significant difference in patients' outcomes. Thank you for your attention, and I hope this presentation has enhanced your understanding of ectopic pregnancy. Please feel free to ask any question or share your thoughts in the comment section. Thank you. We'll have the next part of ectopic pregnancy in the next presentation. Thank you.